physiologic differences in the endocrine system of children and adults, would like to identify those disorders that are common, endocrine disorders that are common in children, and we would like to identify those nursing assessments and interventions and treatments that we use commonly in the pediatric population. And then with all the information we've gathered, we'll be able to plan an individualized plan, care plan, including teaching of the patient and or the family of children that have endocrine disorders. And then at the end of it, we will look at the exam and then we'll look at the exam. Okay. So the endocrine system, we know this is just a review from your AP and also from your patho that you've covered, centuries ago. But I need us to kind of refresh our mind on what they are, because you need to know them in order to move forward, because you have them in not only in peace, but in method. So the endocrine system, there are glands, tissues, or cells that produce and release hormones. Some of them will produce their hormone and release it directly into the circulatory system. Some would only serve as a storage for those hormones that are produced. And these hormones have physiologic effects on the body. They can affect growth and development of the individual. They're also involved in metabolism of the person. They can release they also serve to form a balance between the fluid and the electrolyte in the body. So as part of their function in metabolism, they aid the tissue to produce energy with which we function, with which we all have, or the tissues of the body will have the nutrients and energy to generate and function. It is also, the hormones are also responsible for sexual maturation, which you will cover, or you've covered mainly in your OD. So those are sexual characteristics and functions of the hormones. I'm not touching them here in peace, but I will just mention them so that we just kind of refresh our mind that it is part of the endocrine system. The endocrine system is also responsible for our stress response. The body will, or the individual or body will perceive a stressful situation. The body will send that message to the brain, and that will trigger the production of the hormone that will determine how you respond to that stressful event. So, for this class, we are looking to identify those functions of the endocrine system that are over-secretive, which is the hyper or under production of those hormones. Because when you don't have these hormones in equilibrium, that's the time you have the disease or the conditions that we'll be discussing throughout this lecture. And one thing that I need you to remember is once there is a dysfunction or hypoproduction of a hormone, the basic treatment would be to replace that hormone. To give the body the hormone so that the body will, to mimic the natural occurrence of that hormone so that that body will be able to function. On the flip side, if it is overproduction that is causing the problem, the goal of that management would be to identify the source or what is causing that overproduction, eliminate it, and or by all means decrease the level of that hormone. So if you don't remember anything about endocrine system and its function, just remember this. So these are the endocrine systems that we have and which you are all familiar with. What is the function of the thyroid gland? What is it? You can look at the picture and answer, or you can answer from your head. What is the function of the thyroid gland? What does the thyroid gland do?
Regulate metabolism and growth.
Huh?
Regulate metabolism and growth.
Okay. So, which organ produces it? Huh? Thyroid hormone, which organ produces it?
The thyroid.
Oh.
The thyroid gland. How about the pituitary gland? How about what does the pituitary gland do? Okay. Pituitary gland is the primary gland that controls almost all the glands of the thyroid function. It is in the hypothalamus. We have the posterior and anterior pituitary gland that produces hormones of the posterior and anterior pituitary gland, which we will cover in this class. Okay, so the anterior gland will produce which hormone? Growth hormone, and also the thyroid stimulating hormone. and also your follicle stimulating hormone that triggers the events that happen in their ovulation system that ends with your menstruation if there is no fertilization, and or fertilization and pregnancy if there is and pregnancy if there is fertilization of that right over, matured ovum. We also have the adrenal gland, which controls the adrenocorticosteroids, which are chiefly the minerals or the steroids of the body. We also have the pancreas, which releases insulin and glucagon. The insulin, which is the chief messenger in the body that takes glucose from the bloodstream and transports it to the cells and tissues to be used for metabolism. The parathyroid hormone, the parathyroid gland will secrete the parathyroid, which regulates calcium and phosphorus in the body. Again, the sexual hormones, I'm not touching the hormones of the ovaries, estrogen and progesterone, or testosterone, we are not looking at that therapy. So again, for these hormones, when they are released in the body, if the hormone is low in the body, a signal is sent to the primary organ that regulates or that stores or secretes the hormone to say, oh, the level is low in the body and I want to secrete more to bring that hormone to equilibrium. And that would be a negative and positive feedback loop that this is trying to illustrate. For example, in the face of low blood sugar, the glucagon will act to increase, the glucagon will act to decrease the level of insulin in the bloodstream to counteract that hypoglycemic event. But on the flip side, if the blood sugar is high in the bloodstream, the cells of the pancreas will secrete more insulin that will go into the bloodstream to take the excess, some of the glucose, and transport it to the cells of the body to use for metabolism, thereby decreasing the level of glucose in the bloodstream. So it goes round in that circle, high and low all through. So, having said that, I just gave you like a list of what each gland will do. The anterior, same thing we use with the chart, so this is just like a repetition or for you to kind of see it closely. So, pituitary gland The anterior one would produce their growth hormone, and deficiency of that growth hormone will call it hypopituitarism. It could be hyper oversecretion, or we could have pretergenous puberty when the child will develop, earlier than usual. The other side would be the posterior pituitary gland would result to diabetes insipidus, or when there is inappropriate secretion of antidiuretic hormone. So these disorders we will look at in the disorders of the pituitary gland. So the first one would be the growth hormone. And this is when there is absence or inadequate secretion of growth hormone production. And this can result from any injury or destruction of the anterior pituitary gland. It could be from a brain tumor, it could be from accident, it could be from injury, it could be from anything. Or some of them may be genetic. But quite few of them have no specific cause that have been associated with them. But that is just a disorder, that is just, low secretion of the growth hormone. So when you look at the child on the assessment, you try to plot the growth chart on the on your regular screening, height and weight, and the plotting of the growth to see that that child's growth is kind of not where it should be in terms of growth. We established that when the child at birth, we measure the height and weight of the child, and then by 6 months, what is the height supposed to be? How many inches? Or by 1 year, how many inches do you expect to see? Huh? How many inches? 1 inch?
For a year? A year is like 28
Huh?
to 30.
30 inches? Tall? No. 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 That child will be a giant before you know it. No. So, okay. So what is it? Huh?
18.
18 inches?
You said 1 year, right?
Oh, 1 year old.
Isn't it?
Okay, so how many inches tall do you expect that child?
5.
5 centimeters?
I don't know. I'm just guessing because I just know the weight. The weight should triple. Well, how about the height? Should it double? Yeah. She said
What
yeah.
is it? All right. So you do your physical, you do your health history. What things can you ask to elicit from, when the child is not growing well? What information would you like to ask of the mother or the caregiver? Okay, pattern of eating, what else?
Between your nail. like say if he was born with a certain thing.
Okay,
Like-
congenital problem, okay, what else? Any genetic diseases that run in his family, okay? Any recent infection,
Sickness.
any recent injuries that involve the head? Because these are all, things that can affect the pituitary area. And then when you do your growth chart, you see that it's below what you expect to see for a child of that age, which I will leave to you to find out what that is. In the lab, you will notice that the pituitary function test, they have to do a pituitary function test, and then you see that the growth hormone is low. And this is really what they use to confirm the diagnosis. Every other thing you are seeing in physical assessment and on history is just like a clue that can say to you, okay, maybe this is something that I should be expecting. But however, when you confirm the diagnosis, you use the low level of growth hormone to confirm the diagnosis. Other things you can do also is to look at take the X-ray and look at the bone age on the X-ray, especially looking at the epiphyseal plate, the cartilages, and see how the wrist and see how the child is growing. You also look at the growth factor, which is low. On CT scan and MRI, you may be able to see a tumor or bleeding or something that causes the pressure around the pituitary gland. So, the treatment, of course, will be, first of all, identify the cause of the problem. If you identify the cause, let's say the cause is a tumor or something, then have to do surgery to remove that tumor. Or anything that is causing pressure on the pituitary gland, or that making it not to secrete the way it should be, that should be eliminated. And then you follow that with your growth hormone therapy. So it's low, we have to give growth hormone therapy, and this usually given via injection. Some endocrinologists will order the injections to be given daily, some every other day. So in essence, the medication can be given 3 times a week to daily, every day, depending on how the endocrinologists have ordered the medication. But for the most part, they do the replacement. And this is all initially initiated in the hospital, and then the child can go home on that, and the parents will be taught to give the injection. So it is important that we teach the parents how to do it. We can initiate the teaching in the hospital, and then the home health, the home care nurse will continue that teaching until the parents know how to do it independently, and they'll continue to administer the medication. So as part of the teaching for that mom needs to know how to store the medication. It has to be in the fridge. Same thing we used when we did storage for immunization, we need to store it. Another important thing would be infection control. They need to rotate the site. They also need to dispose of the sharp needles that they are using for that properly. So they can use that is, if you go to these stores, they have like a sharp disposal. They can buy from Walgreens or Rite Aid, or the home care company can give them one. So usually you instruct them to put all their sharps in there and bring it to the hospital during the appointment for exchange of their containers, or the home care nurse will take it from them. Okay? And usually they'll need to come for their regular follow-up appointment, and the physician will monitor this child's growth. Usually the growth hormone will be stopped when the growth plate or epiphyseal plate have closed. So in essence, the growth hormone therapy is not given for life. You stop it during late adolescence and or when the growth hormone or when the growth plate has fused. It is not a therapy for life. We will come across other therapies that we have to do for life, but not this particular one. So, having said that, you would want to monitor this child closely for adequate growth, and you need to educate the family on what the whole treatment plan and the need for them to come for adequate follow-up. And also you need to support the child psychosocial or promote the child's self-esteem. Some of the complications that can happen with growth hormone deficiency would be alteration in carbohydrate, protein, and fat metabolism. Remember, we said the glands which the hormones will aid in the development of the body when there is a deficiency. So you're looking at failure to thrive, failure. That child is not growing as it should. Not enough carbohydrate or protein or fat is making it to the tissue, so this child runs a risk for hypoglycemia. For some reason, deficiency in growth hormone have been associated with leukemia. As a consequence for that, you may also see recurrence of brain tumor. The tumor was removed, and then for some reason, you do the surgery and take it out, and then the tumor will recur afterwards. Sometimes it will be infection from the multiple injection site and or from the surgical site. And also you can have retention of fluid and so any questions with growth hormone dysfunction, hypofunction? Hmm? Any questions on that hyperfunction of the growth hormone? So the other side of that hormone dysfunction would be the hyperfunction. When for some reason the growth hormone is in excess in the body. And you can see two characteristics here. If the problem occurs before the closure of the epiphyseal plate, that is that growth plate in the bone, if that oversecretion occurs when that growth plate is still open, you see a linear growth on the person. So the person will grow so tall, very vertical growth, and that person will, the long bones will be so overgrown and the person will be so tall. Okay. Generally, with that dysfunction during, prior to the closure of the epiphyseal plate, the proportion of height and weight is the same. Okay, so it's proportionally the same, it's in proportion. So you look at the person is nice and tall, but have enough muscle and weight to weight it. However, when the growth hormone is, when there is excess in growth hormone secretion after the epiphyseal plates have closed, so the long bones, the epiphyseal plate is closed, the child has achieved the normal growth, no more growth in the long bone, as you would see. Now you start seeing the overgrowth in the peripheral tissue. So you see the head overgrowth, the side protruding of the abnormality of all the facial muscles and all that. So now the growth is no longer vertical, but you are adding all those excessive weight on the already normal developed height and length that you see. So now you start seeing all these upward shapes in the shape of the head and of the bones. So with that, there is a disproportion between the height, between the weight of the person and all this distortion in their bone facial muscle. Okay, so you see increase in facial hair, and you see there is very thick creases on the skin, which you do not see in the other one because everything is still open and the child is growing nicely, everything is in proportion. So you see that the person have unusually large head with all these bumps in the body. So how do we diagnose this? Of course, we look at the X-ray. So the X-ray will tell you look at the X-ray, you look at the epiphyseal plate, growth plate, see that it's still open, but there is excessive secretion of the hormones. And for this also, we look at the X-rays and the scan if there is a tumor or something that is pressing on the pituitary gland that is causing it to secrete excessively, that we identify on those scans. They can go into surgery and remove it to decrease secretion. And they will also follow it up with radiation. And one thing that has happened most often is that once they remove, depending on the extent of tumor in that, the extent of involvement of the pituitary gland, they may take partial or all of the pituitary gland out in an effort to remove the tumor. And after that, they have to augment the treatment with hormone replacement at times. So depending on what they did. If it's just to go in and just a tumor pressing on it that is causing it to or making overgrowth of the tumor itself, they can take it out, and if it's able to produce enough for adequate growth, they don't do any replacement. But if it's not enough after they remove that tumor or they remove part of the pituitary gland, then they can augment it because we need to still sustain growth until the child is able to live without the hormone. So another problem with the pituitary will be the fact when you have a sexual when you have the disorder whereby the child develops all these sexual characteristics prematurely. You can see as a child young as 7, developing all these sexual characteristics with breast and including sometimes menstruating at the early age. This can be as a result of disorders of the adrenal gland or disorder of the hypothalamus pituitary gland. Unfortunately, majority of these cases have really no cause, so 95% of them have no specific cause to it, but it just happened and then the child develops all these sexual characteristics on, prematurely. And you can imagine a 6-year-old or 7-year-old in a class with their peers and they are the only ones that have all these sexual characteristics, including changes in their voice and everything. So they will look like very odd in the midst of their peers. So they have all these things that you will notice in adolescents, but they're very young. So it's like a mini adolescent in a small body. And that could be very, very troubling for the child involved and again for the family. Because, they take the child out, they'll be like, how old is this child? What is this? And, all kinds of questions will be asked. So that can lead to the emotional dysfunction of the person, because you see that child with unnecessary growth, including mood swing and all these growth problems. So what is the treatment here would be because it is excess hormone and it's increasing the maturity of the person, will try to retard that growth. And their first line of treatment will be to give the Lupron, liquor, every month. And this is luteinizing releasing hormone. And the aim of that will be to slow the puberty. Again, this is one of the treatments that they can give temporarily. So you give it until the time that the child reaches the appropriate age for normal puberty to kick in. Then you withdraw the hormone to allow the normal child to grow normally. Okay? So, and this will aim at stopping the treatment at age 11 for girls and 12 for boys. So in essence, what the treatment does is just to slow or to retard that, rate of growth, because this child is 6 years old, 8 years old, 9, and developing all these sexual characteristics which they shouldn't at that young age. So you give the hormone to slow the progression. And then once the child reaches the age for normal puberty to kick in, then you kind of withdraw the hormone and then allow nature to take its course. So it is not a lifelong treatment. Okay? So this child needs to come to the clinic regularly because we'll need to monitor the child's growth. So with that, we need to educate the family on the need for that child to come to the clinic to keep to those appointments. We need to also educate the parents about the medication side effects that they need to watch for. Depending on how the child or the family responds to their event. In fact, this child may or most often be referred to a social worker for counseling. Any questions with growth hormone? So for growth hormone, we know that it is a hormone that is released by the anterior pituitary gland, used for growth, appropriate growth and development of the child. Its functions can include hypo and hyper secretion of those hormones. The dysfunction can be as a result of injury to the pituitary gland. It could be due to an infection. It could be due to a tumor or growth. And sometimes, the majority of them have no specific cause attached to it. The strategy for treatment will be to confirm your diagnosis by the low level of growth hormone in the body. For the deficient hypo secretion, and for the hyper secretion, you have excessive growth hormone level. Treatment will be aimed at identifying the cause of the problem. If the cause is a tumor that is affecting the pituitary gland, that is compressing, tumor of the brain that is compressing on the pituitary gland, then we need to remove the tumor and then do the radiation therapy. If it is a tumor that affects the pituitary gland on its own, they can take the entire pituitary gland or part of the pituitary gland and still give the radiation therapy because you need to eradicate that source of the tumor. Sometimes leukemic cells have migrated to the cerebral vessels and lodged in the pituitary gland. In that case, you have to do the, if you identify that as the problem, they have to do the intrathecal chemotherapy plus or minus radiation to take care of that. Once the pituitary gland is taken out, there is a need, there is a need, if it's taken out completely, there is a need to give artificial growth hormone until the pituitary plate closes, if it's taken out completely. However, in the case of hyposecretion, you will still have to give the growth hormone subcutaneously from 3 days a week to daily, depending on how the endocrinologist decides to do the therapy. Treatment is initiated in the hospital. Patient goes home. Mom is taught, or caregivers are taught how to administer the injection. They will administer it, so you need to teach them appropriately the role of the indication for the medication and what they need to do, including rotating the site and disposing of the shaft correctly. Including also the need to support the child and family who have the growth hormone deficiency. In the case of hypersecretion, again, we'll need to identify the source of the problem. Why is the pituitary gland oversecreting? What is the problem? Then we identify the problem, and then we would like to treat the problem or remove the problem. We would also like to decrease that, secretion of hormone, because over-secreting it will be too much, and that's causing the overgrowth. The child will grow vertically when the epiphyseal plate is still open. But after the epiphyseal plate is closed, all the other growth is already on the existing normal body structure, so you start seeing upward in all the bones, facial bones and bones of the body, because the bones are just mounting on what is already secreted. Okay. For that condition that is abnormal or premature development of sexual characteristics, again, you give the hormone Lupron before to help to retard the rate of, to slow the progression. And then once that child reaches the age of normal puberty, you withdraw the medication and allow normal puberty to take its course. So in the conditions that we have treated so far, none of these is a treatment. We don't give treatment for lifelong. Okay, these are all temporary treatments that once we achieve the goal of that treatment, we will withdraw the medication. Okay? Any questions? Okay. So, continuing on disorders of the pituitary gland. So what we have done so far is disorders, things that affect the anterior pituitary gland. So this time around, we're looking at dysfunctions of the posterior pituitary gland. So the posterior pituitary gland will have, we have those hormones, the anterior antidiuretic hormones that are secreted, and the problem will be, for some reason, there is less secretion of antidiuretic hormone and oppressing hormone. And this results in excessive production of urine. So, we have two types. The central type and the nephrogenic type. With the central type, what happens is that, it affects the posterior pituitary gland and results in under-secretion of the antidiuretic hormone, which usually is the hormone that will regulate the renal tube, will result in the reabsorption of fluid. But what is happening, because it's less, it's not functioning, it's allowing a lot of fluid to be secreted, and you have so much fluid in the being eliminated in the body. So what you see is that that can be from trauma to the pituitary gland, and because the renal system is not sensitive to those, the antidiuretic hormone is less, so it's like free for all. Now, the other one is the nephrogenic type. And this nephrogenic type is a result of, it's genetically transmitted as a sex-linked transmission. In fact, it can be sex-linked, it can be autosomal, autodominant, recessive, and dominant. So in short, the nephrogenic is genetically transmitted to the children. And that results in the kidney's decreased response to antidiuretic hormone. And then you will see that most commonly with associated with chronic renal diseases, where you can have hypo and hyperkalemia in this instance. So, treatment for this is requires a lifelong treatment. So, what happens in diabetic insipidus is that because of that deficiency in the antidiuretic hormone, the kidneys, the antidiuretic hormone, which is involved in diluting the urine, or in concentrating the urine, rather. It concentrates urine, but because there is a deficiency in that antidiuretic hormone, okay, it's not doing what it's supposed to do. The urine is not concentrated enough, it's very diluted. So the kidney loses a lot of fluid. As the kidney is losing fluid, it's retaining sodium. Because if you remember, in that renal tubule in the Bowman capsules are part of the filtration system, okay? So now what is happening is that the the kidneys, because of that deficiency in antidiuretic hormone, all their water is being eliminated. Now the kidney is just holding on to the soluble, which is the sodium. So you have increase in sodium. In the serum, sodium is high, and then the person is just passing urine. And with that continuous elimination of fluid, you will see their altitude with the need for the person to drink to replace what is being lost. Again, in the serums, in the system, there is high sodium, and that can increase that concentration of sodium in the blood, which will also lead to increase in thirst. So the two signs for that condition would be the polyuria and polydyspnea. The need to void a lot and the need to drink to replace what is being lost. For the infant, one thing you will notice is that the child is very irritable, and when you give them formula, they'll drink the formula, but they're still very irritable. As soon as you give them water, they're fine. So there is that need to satisfy their need to drink water. So here often dehydration will occur in the person because of that constant elimination of fluid. So some of the diagnostic tests that we'll do here will include CT, MRI, or ultrasound. Again, we are looking for any tumor or any lesion in those areas in the skull that can affect the pituitary area, or those anything that can affect the kidney itself. When they do the fluid deprivation test, which is something that is done to confirm the diagnosis, what is happening is that once you don't give that child fluid, water to drink, you withhold water and then look for the response of the pituitary gland. Once you hold off water, you just want to look at the release of vasopressin or DDAVP hormone release from the pituitary gland. You would like to see a decrease in urine output and an increase in specific gravity, a decrease in urine output and an increase in specific gravity, meaning that the body is able to hold onto fluid and also it's able to maintain the specific gravity of the urine. And then when you look at the sodium serum, there should not be any change. But in the face of diabetes insipidus, what is happening is that you will see an increase in urine production, and also you will see that the specific gravity of that urine is decreased. And when you look at the serum sodium, you see the sodium is high. That's what you see in diabetes insipidus. But when you deprive the person of that water, you see that this change that you see there, and that will confirm to you that yes, there is a problem with antidiuretic hormone. Right. One thing you should, yes.
Just a question about, will IV fluid transfusions satisfy the dehydration process of a child, or not necessarily?
Yes, you can give, yeah, we do give the IV infusion, but we need to give the PO also for the child to. But when you are doing the fluid deprivation test, you do not give PO at all. You don't, and you kind of hold off on the fluid because you're doing it for a very short time to confirm your diagnosis. And one thing we'll advise parents to do is not to drink in front of that child, because already that child is thirsty, and then you are drinking in front of them when they are not getting anything by mouth, especially water that they really are craving to have. So we advise no sort of anything water around them. That way you do your test for that short period of time, take your measurements, and then resume your fluid intake. Yes. Any other question? Any other? So now we did that fluid deprivation, and we said that in normalcy, what we see in normal situation, when everything is okay, you don't give somebody fluid water to drink. What you see in normal situation will be you have decrease in urine output. The specific gravity of that urine is high, that they will void eventually because the urine is concentrated. And then you look at the serum glucose sodium, there is no change in that. However, in a patient that have diabetes insipidus, you see that their urine is still diluted. Their urine osmolality is very high. The serum osmolality is high. There is a decrease in specific gravity of the urine, and there is an increase in sodium level in the blood. Sodium level is high. High sodium level, high osmolality, decreased diluted urine with less specific gravity. So this is also saying it in other ways. And that is what confirms your diagnosis. So again, your treatment will be to replace the hormone that is lacking, and the drug of choice here will be the DDAVP, and that can be given as a subcutaneous or oral or nasal spray. And again, as with all medications that we give, or most medications that we give in pediatrics, we dose the medication according to the child's age and weight. So you do the age, weight, and then the urine output. So this is one of those times that the endocrinologist may write something very similar to a sliding scale of insulin. So they look at the total 24-hour output and then write a prescription for the DDLVP for that time. So you may see them doing that, and of which most of them do that most often. Okay, some of them will just give you like a blank this thing and say, okay, this is what we need to give for so and so period of time. Again, we need to monitor the child's urine output. If a child is boiling equal to or more than 1,000 milliliters of urine per hour for 2 times, you must notify the physician. You may notice that some of them would have a total output of more than 3,000 per day. That is still a lot. But if the child is pulling up to 1,000 milliliters of urine or more per hour, you need to report that to the physician, please. So that brings us to our need of importance for us to monitor the child's hydration status, and we also need to educate the parents and or the child about the differences between diabetes mellitus and diabetes insipidus and their characteristics, because these are 2 different conditions. Diabetes insipidus affects the posterior pituitary gland. Diabetes mellitus has to do with the pancreas and insulin. So we need to tell them that. Characteristics of the 2 is different as well. Diabetes insipidus will be what? And what is the symptom? Okay, and diabetes mellitus will be what?
Low insulin or insulin.
Okay, and then what is the symptom? You can see diabetes mellitus. Yes? Okay, what is diabetes mellitus? What is the cardinal symptom?
Lethargy.
Huh?
Lethargy and
Yeah, you eventually that person is but what is you are actually cardinal signs for diabetes mellitus. Eric, what is it?
Sorry. The diabetes mellitus?
Yes.
Well, you need insulin therapy. So,
I'm looking for the symptom, the 3 P's.
the 3 Ps.
What is it? 3 P's. Okay, polyuria, polydipsia, polyphagia, and then you know for diabetes, insipidus is only two P's. They sound alike, they look alike, but they are not the same. Okay? So you have to kind of note that. Any questions to DI? Yes.
Also for the oral, it's just a concern as
Yeah.
$1,000 per hour.
Gia. I don't want to listen to her anymore.
I don't want to be a
Okay,
pain.
the question here is,
I don't want
the
to.
question here is the concern about intake and output. Is it only for the 1,000 milliliters? The answer is no. What is the concern here is if the child has a urine output of up to or more than 1,000 milliliters in an hour, twice in a row, we need to let the doctor know right away. That is excessive. Sometimes they can pull up to 300, 400. Remember, this is a child. They make even an adult. I mean, I don't care how full your bladder may be. You go in there and then void you have like 1,000. You have to go urine out. So see the length of how the size of you have it full and it's overflowing within an hour. Something is wrong. Okay, so something is wrong in that picture. Because in 24 hours, with patients that have diabetes insipidus, their total output in 24 hours can be as much as 3,000. And then on the flip side, you're looking at it, the child has 1,000 just within an hour or two. At most, within an hour, they do it twice, and that's a total of 2,000 in 2 hours. That's a lot. Okay. Another thing we need to watch out for will be water intoxication. Okay. Yes, we're trying to replace, but again, look at the cerebral symptoms. Okay, that child is start becoming irritable. Look at your vital signs. You need to monitor that child very closely. Okay. Any other questions? Yes, Jackie, you asking your question or you're just trying to fix yourself? Any other question? Susan? Oh, yes. Okay. All right, so we move on to all right. Okay. So the next problem we're looking at will be the syndrome of inappropriate antidiuretic hormone. And in here is the oversecretion of the antidiuretic hormone. In diabetes insipidus, we are looking at decreased antidiuretic hormone. Here we are looking at oversecretion. Okay? So here, the body retains water. And this is, can be associated with infection of the cerebral central nervous system. And that child can become irritable. When you look at the child can become irritable, or you can see like nausea and vomiting, which is non-conclusive of anything. But when you do your labs, you see that your sodium level is low. Unlike in diabetes insipidus, where we have low antidiuretic hormone, we have retention of sodium in the blood, and there is increase in osmolality. But here the reverse is the case. So what do? We would like to correct the problem. And here we'll also like to maintain fluid restriction, and also maintain the level of sodium in the body. Because the sodium now is low, so we'd like to maintain it so that we'll be able to increase the sodium osmolality, which is low here. So that's really basically what we're doing in that particular one.
Is
Yes.
it increased sodium?
Huh?
You said it was low, isn't it increased sodium?
In the urine?
Yeah.
Sodium is high in the urine. But in the blood, it's low. Yes.
So low sodium.
In the blood, serum sodium is low in the blood. Yes. It's low in the blood. In DI, it's high in the blood. And osmolality is high in the blood. But in this, low sodium in the blood and low osmolality, and you would like to increase the sodium level in the blood. Yes.
This one's not lifelong treatment, right?
Huh?
The SIV. Is it lifelong treatment? It's not.
Treat it for 9 years, depending on the condition, depending on the cost. But the ones that are very classic, the ones that are up in the air,
Yeah, I think we should.